morning, I'm Dr. Yusuf. I'll be presenting to you 26 cases of J-Cannula Cortical Cleanup. I just kept the J-Cannula part to not to be too boring. The rest of the steps are the regular cataract steps. And I'll give you the tips and tricks about the use of the J-Cannula. First, before I start, I have to confirm that you understand that the J-Cannula is attached to a 10 cc syringes on a BSS, and it has to be very tight and luer locked, and you have to check that every time. Otherwise, the J-Cannula will eject. The second thing, you have to make sure that you're in the correct location. So in this case, for example, you have to make sure that it's in the bag when you put it in, because you can go easily in the sulcus if you don't see the edge of the capsular access. So you slide it on the posterior capsule and go to the usually go to the right side and inject, and it will split the cortical layers from the capsule, and the wave will go across the capsule and go out on the other side. I'm not changing the speed. You can see the timer on the right side, right bottom side, showing the time from the start of the J-Cannula step, and you see how effective it is. And this is the actual speed, not unedited. And the clip sequence is up on the right. It shows you the number of videos, and that was done that day with the J-Cannula. So it's this is video number 3, for example, and it's 27 seconds into it. You go in horizontal, and you go. I usually go to the right side. Start injecting to develop a layer between the capsule and the cortical material, and start injecting. You can see the wave going across 270 degrees to the other side, splitting the cortical material. And then I go flip the cannula to the opposite side and inject until the cortical material collects and gathers and comes out. And then I do a sweep across the posterior capsule, cleaning all the small material. The nice thing about this technique is that you can actually clean areas that you don't see. You have to make sure that the capsule is intact, and you go in, and even if the pupil is not fully dilated, you can still do it with precautions about the iris prolapse. So you have to keep an eye on the wound to make sure that the iris is not getting ready to come out. You control when you inject with the J-Cannula, you're irrigating, and there's no aspiration, but the fluid will come out along the J-Cannula through the wound, comes out through the wound. So keep an eye on the wound here. And all these cases are just the same regular speed, same tick. You go to the inside horizontally, I usually go to the right side and flip to go to the left side. Sometimes I flip inside the eye if my hand is comfortable doing that, or sometimes I bring the cannula out and flip it on the outside. So you can clean up all the cortical material from the fornix of the capsule, and you can even remove the small cortical nuclear material from the anterior chamber the same way. I think that there's one case that shows that. You just irrigate it out. So I usually go to where the paracentesis is to remove any debris in this area. And if there's a small nuclear or cortical fragment that's still holding, you can actually hook it out when you're leaving the eye to remove this piece out with the J-Cannula while it's coming out of the eye. It's a very safe, effective technique. I did thousands and thousands of these cases with the J-Cannula, very effective. But the precautions, again, you have to make sure that you are in the correct location. If you go into fornix and inject, it's not safe. I usually now inject only almost with the J-Cannula horizontal. So even if you're in the sulcus, see here, I'm removing the nuclear cortical material from the anterior chamber, that way from where the paracentesis is. So this is a small pupil case. I didn't need to do malignant ring or anything, but we were able to do it without dilation. So you can see the J-Cannula, don't see where it is, but you have to make sure that the J-Cannula is in the capsule. So this is by sliding it across from the center of the posterior capsule and sliding it across to the areas where the cortical material is underneath the anterior capsule. So you're making sure that you are inside the capsule. The same idea. I do bilateral cases, so these all bilateral. You can see that the iris is the same between the two eyes. They're all bilaterals except for the last couple are singles. but mostly bilaterals. And you can see it's a small pupil. You can safely do it. With IA, you don't see this area. You're scared of going too far behind the iris, because even with bimanual, it can still capture the capsule and rip the capsule. So this is a much safer technique to do that. So it's the way to go, actually. I'm not sure why are people not adopting this technique as their primary cortical cleanup methods. And again, this is another small pupil. Keep an eye on the wound. Make sure that the iris prolapse doesn't happen. And you control pressure and flow by controlling what's happening at the wound with the angulation. So how I hold the 10 cc syringe and the J-Cannula, I hold with my right hand. I'm right-handed surgeon. With my right hand, I'm holding the syringe, and with my left hand, I'm holding actually and directing the J-Cannula itself. I'm probably getting a refill. Sometimes if I run out of the 10 cc syringe, BSS, I just refill and come in. One of the major precautions here, you should not run out of BSS. So if you're getting low on the amount of BSS in the syringe, come out, refill it, and go in again. Because if you run out while you're inside, there's a Venturi effect that would happen. Will suck the capsule, and it will have a hard time to release it. So you saw that the last part, I removed a small nuclear fragment using the J-Cannula from the angle. Usually the debris, those little pieces, collects where the paracentesis is. It's usually 80 degrees to the left of the main incision. So I usually clean this area up either with the J-Cannula if I see something, or during the hydration of the wounds at the end. I start by this, so I remove all the small debris from the area where the paracentesis is, because this is where the flow is going sometimes during the surgery, so the debris collects in that spot. Now it's case 13, and I want you to notice the timer is very effective and safe, and it's the way to go. So again, if you run out of the fluid, you can refill and go in again. You can and you finish. The idea is that once you implant the lens, now the lens is used as a shield. So if there's a stubborn part or something like that, you can clean it up after you implant the lens. I don't go with irrigation aspiration behind the lens ever. I feel that this is dangerous, although people do it frequently, effectively, but I feel it's not safe for me. So I use the irrigation only technique. So after I implant the lens and there's small pieces maybe behind the lens, you use the hydrodissection cannula on the 10 cc syringe, and you clean up behind the lens without having to go with the IA. IA, for me, without having the protection of the shield of the lens, is dangerous to open the capsule at this stage and ruin the surgery. So J-Cannula is much more effective and safe. Again, the tricks are very simple. It's not an easy technique to get used to, because it's a change from how we trained and how we did things for years. But it is a technique is worth adopting. The stuff we need is simple and available. There's reusable cannulas and disposable cannulas. So the one I'm using here is from Alcon, 27 gauge J-Cannula, and on a regular 10 cc, but has to be lower locked, of course, otherwise can eject. The other cannulas you can use, I use also 25 reusable cannulas, which I like too. The flow is much more and much faster to clean up the cortical material. But 27 is good, and 26 or 25 is good too. One of the things you need to remember is that you are manipulating the J-Cannula by both hands. Actually, the right hand is holding the 10 cc syringe, and the left hand is holding the cannula, making it sure it's secure to the tip and is directing it and controlling it. So it's very effective. Again, you see the same technique. These videos are in real speed. They're not sped up. They're regular speed. And we are case 18. So the whole video is less than 15 minutes, and it's 26 cases. And if you have any comment or questions, just send me a comment or a message to my email. I'll respond to it. So again, you go inside and center, go to the right lower thing, the right lower area, and start ejecting there to develop a layer, a hydrosection layer between the cortical material and the capsule. And the wave of the fluid will go down in the fornix of the capsule, splitting the layers there and going out on the opposite side of the capsule. And then the fluid will rotate and circulate in the anterior chamber, going out of the wound. So it's a circle, and it goes out through the wound. One time I was checking the J-Cannula, make sure it's tight enough. Actually, it wasn't tight, and it ejected and hit the surgery list on the wall across the room, and it was scary. And showed the nurses that, and showed them how important it is to be very, very, very tight. So the best, when you want to split the first layers, the best is to get the flow to be across the cortical fibers. So when you go across the cortical fibers will start rolling to the side and opening that gap, and that's where you can go in. So when you go, this is across the cortical fibers. So you develop this hydrosection plane again, and so you split the layers from the capsule, and the cortical material start leaving the eye. So this is the idea, and the direction. I used a different kind of J-Cannula. So I have this design from Alcon. Sometimes you can bend it a little to give it a little bit more reach. So I have that design too. I made multiple modifications of the J-Cannulas. This is a disposable one. The rule in the hospital is to use disposable things, so I'm using this one here. But in the private center, I use a different design of J-Cannula. With it's a little bit more effective. I made it a little bigger, so 26 and 25 gauge, and develop a slight angulation, so it can reach a little bit more than this one. Again, we're in case 23, sorry, out of 26, and you can see none of these cases will capture the capsule, capture the edge of the rexus. Sometimes when you going out of the eye, you can, remember it's a hook, it can hook anything. So it can hook the edge of the capsule, edge of the iris, the wound itself. So you have to remember your location. And if you position it horizontally when you're moving out of the eye, you will avoid capturing all these parts of the eye. The complication that can happen from J-Cannula are simply related to ejection of the J-Cannula. So if you don't make sure that it's very tight, it can actually eject and cause major complications. So happened to me once. The nurse forgot to tighten it, and I forgot to check it out. And this was maybe in 2003. So that's a long time ago. The other thing is can capture anything. It's a hook again. And this is the thing. So the third thing that can happen if you don't confirm the location of the J-Cannula, you can actually hook the edge of the rexus. So I did that once too. Once you do it one time, you'll learn your lesson, so not to do it again. See, there was a nuclear material here at the paracentesis, and I removed it that way. This is the last case here. The rest of the day was suture lenses, explantations, and IOLX exchanges. So the rest of the lenses we did not need to use the J-Cannula for that day. Thank you for watching, and if you have any questions, please contact me. I will be ready, more than ready to help you out with anything that you have in mind. Thank you very much for watching. Have a great day.